First thing I want to talk about, though, is a little bit about kind of the models of medicine and what that's driving from a pattern perspective, and to really kind of set up the stage for precise medicine. If you look at some of the panel members here and what they mentioned, real-time, data services, quality services, things like that, it's all being driven by different models of medicine. You know, we're shifting to consumer-based models of medicine. We talk a lot about consumer-based models of medicine, but trust me, to really serve consumers as consumers, we have to move to real time. It's the only way they'll use applications. You guys have probably Apple or Android devices. If the application doesn't give you data in real time, what do? You hold the button and you hit the X and delete it. That's just kind of the way we operate as consumers. So we have to move to real-time systems. The other thing is, we're moving to this whole prevention-centric model, proactive model, and this is being driven mostly by incentives, you know, around value-based incentives or alternative payment methods. So when you move to those models, you have to be much more proactive in your models of care. So population health is a big buzzword. You hear a lot of that, but it's really about proactive models of care, not reactive models of care. And then the final thing is around precise medicine or predictive medicine. How do you understand somebody's genome or other attributes, phenotype attributes that will drive kind of the care that these people need in the future? So those three things are some of the patterns that I want to set up and talk about a little bit. So I think most of you have seen many of these stats, and the only reason I put this stat up here is to give you a sense of kind of how much is related to social and behavioral. I think one of the panels mentioned the worm. It was such a social or behavioral kind of change required to actually change the disease. As you can see, that's one of the #1 determinants in changing disease states. But genome is pretty high, and I'll talk a little bit about a personal story. So genome and understanding kind of all the genomes, not just your variations, but your microbiome and the other types of genomes that go along with it. And why is that important? Because if you think about patients and you think about precise medicine and where this is going to very much more precise care plans, a patient record is going to look different than a patient record does today. It's going to have much more data than we've ever seen. And if you look at this and you imagine that you have genome, proteome data, microbiome data, social behavioral data, clinical claims data, biometrics, you know, because you're using wearables or you have professionally monitored devices, you could be up to 2 terabytes of data. So when you start thinking about data and data sets, you have to think differently about the technologies. So it's going to drive different patterns for you and different types of technologies than you currently use today. And I'm going to suggest some technologies that you should look at that others are using in the industry today that will impact you. And I think this is pretty obvious. Actually, we've been doing some work with some medical genomics center, and I think this number is small because the amount of variation data that we put into our systems was going to blow away these numbers. So it means your systems need to be much different to work in these worlds of proactive and consumer-based medicine models. So what does that mean for a doc or a patient? You know, they got how many variables? You've heard the story about how many variables the human brain can handle, a couple variables at a time. And now you're talking about 1,000 variables. We need to provide better cognitive support for our docs and our patients. And this is where I'm going to tell you a little story about how we're not doing a great job. How many of you know what cystic fibrosis is? Pretty tough disease, right? Pretty tough disease. So I have a son with cystic fibrosis. He's the 8th grader, as you can imagine, right? Because they normally have thrive issues. They're smaller. That year, he could only play 2 games, 2 football games, because typically he gets sick, goes in the hospital for 10 to 12 days, has a PICC line, then goes home for 10 days with a PICC line. It's a very, very tough disease. He would do this every 3 to 4 months, hit ED. He would have sinus surgeries once a year, bronchioscopes. He had all kinds of meds, doing 2 treatments a day. It's pretty tough disease, but he loved football, absolutely loved football. Reality, though, is the way he was going and his lung function deteriorating and his thrive issues, he wasn't going to be able to play, you know, as you got into high school. It was just too difficult. Now I'm going to fast forward a little bit. This is his junior year. So about 4.5 years ago, I live in the Phoenix area. That's why I have so much color, by the way. We were at 115 the last 2 days. It was brutal. It was brutal. It was absolutely brutal. And I was in the pool with my kids all weekend. So this is really nice weather. But so 4.5 years ago, I go into Phoenix Children's Hospital because I live in the Phoenix metro area, and you know, there's about 4.5 million people in that area, and there's one CF clinic. And I go to see my doc, and I say, Doc, hey, I'm really excited about this new drug for my son because he has this variation. And the doc says to me, he says, he can't take that. And I go, no, he can take that. He has that variation. It's designed for his variation. And I keep arguing with him, and he goes, okay, let me check. So he looks through paperwork, you know, and he goes through a bunch of paper and finds it. And he looks at my son and says, Carter, this is a game changer. Now, if you just pause there for a second, if I wasn't following the variation, I didn't know the drug pipeline, and I just listened to my doc, what do? I walk out of there, and just, he doesn't look like this today. He absolutely doesn't look like this today. So I don't think we're doing a good enough job for our docs or our patients, because there's no way in 10 to 15 minutes can he provide enough information to that doc to actually prescribe the right therapies for my son. It's impossible. Now, this is one example of an orphan drug for a specific disease state. How many more do you think are coming? Look at where pharma's going. It's going towards specialty and orphan. So what do you think is going to happen to our systems? They're going to have to get real time at the point of care. Otherwise, our docs are not going to do a good job. And we have to help our docs, and it's not a doc problem. My doc was a great doc. He just didn't have the tools and too many variables. By the way, the person that mentioned Jimmy Carter, is she still here? I have to tell you, know what his name came from? Jimmy Carter is a distant cousin of mine. So that's my great-grandmother's maiden name was Carter. So that's where he got his name. So that was an interesting story. So let me fast forward a little bit. His senior year, he became the captain of the football team. Which one do you think he is? 15, 63? He's 63. So he got to about 6'2", 225, and now in college, he was actually capable of going off to college. So 4.5 years into this thing, the kid is now really a big kid, and he looks like a normal kid. I mean, he doesn't look like a kid with CF. His lung function is stabilized in the high 80s, low 90s. He can play sports. You would not know he had CF. You met him, you would absolutely not know. But prior to that, you knew he had CF. I mean, he struggled. He absolutely struggled every day of his life. That drug actually changed his life. So precise medicine, no matter what anybody says, is really here today. It's absolutely here today. And I don't think our systems are designed to handle it. And I think things like MiHIN are set up really well to provide services, especially in the cloud or in a data center, to actually provide some data services to hospitals and to patients to actually drive better care in the future. So I think even technology is going to change and where this goes. So what's needed? I think a different type of patient record, a much more actionable patient record that understands more about not just the patient from a clinical or claims or pharmacy perspective, but also social and behavioral, the genome data, microbiome data, all that data to actually make it much more actionable, and the care plan, to understand the care plans there are and learn so you can optimize those care plans. So this patient record is going to be very different than the patient record we actually see today, and it's going to require different kinds of systems. So what I'm proposing, and I'm not going to do a product pitch here, but what I'm proposing is that the technologies actually exist today, and we don't use them in healthcare. And I think we have an opportunity to use them in healthcare. If you look at how many know what Cassandra is, have you ever heard of Cassandra? How many have Apple devices? So did you know that Apple has 75,000 to 80,000 nodes of Cassandra deployed today on these? Do you know what they hold in these systems? They movies, music, notifications, messages, email. What else does Apple provide to you? All those services are all in the cloud on the system, backup. Now, why is that important to you? If you think about data sets, remember I talked about data sets. If you need to support unstructured data, structured data, clinical data, claims data, biometric data, variation data, all that data looks different and different sizes. In fact, Instagram and Twitter on that slide use Cassandra too. And they use Cassandra for a different reason. Does anybody use Twitter and Instagram? Several? Well, it's a pattern that's really important that you need to understand, because consumers are going to be very interested in this, especially when you get to biometrics and you're actually doing maybe what the gentleman's going to talk about tomorrow around the patient-centered data home or whatever that might be. We're going to use more and more data to drive care, and that pattern of post a message, post a picture, and all my followers see it now is a concept of fast write, fast read. That same model is going to apply for biometrics. You're going to be monitoring biometrics, looking for threshold issues or issues in general with the biometrics. And it's a fast write, fast read that my care coordinators or my care team is going to see it in real time. And trust me, we have some systems deployed with 12 to 15 million longitudinal patient records in it today. If they turned on biometric without that kind of technology, they would choke. They would disappear. They would bring them to their knees. So you need to support these kind of new patterns that you're going to see in the future. The other pattern that's interesting in this is Netflix and Hulu actually use Cassandra. Did you guys know that? Do you guys use Netflix? So why again? It's a different kind of data set, right? It's a big file with a player at the endpoint, a video player. It's either on your TV or on your phone or whatever your device is. That looks no different than what? An image or a variation file. An image is a very big file with a 2D, 3D, or 4D player at the endpoint. Or a variation file from a sequence, from the analysis of the sequence, where the variation file could be 100 megabytes, 250 megabytes, or half a terabyte that you might store in this system that has some kind of genome browser at the endpoint. So again, data sets need to be important to you when you're thinking about your technologies and the patterns you need to support for tomorrow. Because we can talk about clinical quality measures and all the other things, but healthcare is going to consumerization, and it's going to precise medicine. It's coming. That story I told you is real. And you're going to see more stories like that. You're going to see more molecules built specifically for microstratified populations that are going to change their lives. And it's going to mean that we're going to have to provide more information to our providers and our patients at some point. The other thing that's interesting about Cassandra, it's open source. It's Apache open source. Why is that useful from an investment perspective? Why do you guys think that's useful? Not just that. Just think about the number of engineers and developers working on this today. Think about the evolution of Cassandra today from where it was 5 years ago. You compare that to any proprietary system you buy, you're not going to stay up with it. Plus, all the third-party components being built around these tools and these platforms. What does that mean for you? You protect your investment. Because if you're investing in these stacks, which you will someday, trust me, if you're investing in these stacks, it doesn't matter if it's from us or build it yourself or buy from somebody else. You will invest with these kind of technologies. There's going to be all kinds of enterprise tools wrapped around these technologies that protect your investment long term. Because when you deploy these systems with that much liquid data, they're going to be in there for 10, 15, 20 years. You're not going to replace them. They'll be way too difficult. So you need kind of this community open source context to drive innovation on that core data platform. Does that make sense? Because it's getting more and more powerful with every year. The other two technologies that you should look about, especially as you're talking about gaps in care and quality measures, risk adjustments and scoring and all the other things that might occur, or how you're going to be reimbursed based on the measures, is how do you do this in a Google or a Bing-like capability? How do you do the ad hoc queries that quick from a provider perspective? Most systems today aren't built that way. They're built in a way where they go from transactional system to operational system to data warehouse to workflow or engagement system. And you guys know those are dumps. Those are truckloads of information going from each system to get down to a panel to actually feed it to a workflow or an engagement engine. I suggest you don't need that. Apple doesn't need it. Netflix, Twitter, Instagram doesn't need it. You can do it in these real-time systems. Bing uses Elasticsearch today. They use Elasticsearch to give you that really quick ad hoc query capability. They don't tell you that, but Microsoft uses that technology. And why is that important? Because you might ask a question from a provider perspective, what measures have I taken care of for my panel today? And because it's real time, it's getting updates and it's only giving the measures that haven't been taken care of. And if you're doing that in a community context, you need Google-like speeds. What happens? Look, even if you're a provider, physician, care coordinator, you're going to expect that that thing returns the results pretty quick. Otherwise, what do? Delete the app. That's the way we look at these things. So it's really important when you look at technologies long-term, how do you pick technologies that support the patterns of today and tomorrow? Has anybody heard of Spark? Good. I have a couple that have heard of it. Spark is one of the leading analytics engines in the world, in-memory analytics engines in the world. Now, why is this important? Spark has 40-plus operations today, SQL native. It has native plugins to BI tools like Tableau and Cognos and all the third-party tools, native plugins to ETL, has native plugins to R, machine learning libraries, SAS, SPSS, out of the box. Again, what does open source give you? It gives you this ecosystem of plug-in capability that protects your investment long-term, plus it gives you choice. You're not locked into an analytics engine that is black box proprietary. If you have a specific model for stratification that you like, you can plug it into a Spark engine. And you can spin up 5 nodes on Amazon, do the stratification, and spin them down, all like that. So those kind of technologies are going to drive the future solutions that are going to be required by us as a health system, both payer, provider, and what a patient's going to expect, and even a provider is going to expect this. So those 3 technologies, or derivatives of those technologies, I promise you in the next 5 to 10 years, everybody's going to be looking at deploying those, because you have patterns that you have to support that look like the patterns that we're seeing from consumer-based solutions today, or cloud-based solutions. So now I know I'm preaching a little bit on this, and I'm pretty comfortable with this feeling, because I did start my own company, I think you mentioned, and we grew it. We became the number 1 B2B integration company in the world. We had 11,000 customers worldwide, 90% of the Global 2000, and my product was built just like I told you. I had a B2B integration broker, I had a workflow BPM product, I had an analytics product, I had an activity monitoring product, and they were all separate 4 products. And I'd have to move the data between those 4 products. Today I can run this in an AWS environment on a single stack, all in real time. All event-based real time streaming. I couldn't do that in the company I started back in '96. So these technologies are going to change compute and change the way we actually build applications, because, look, consumers and providers are going to expect this in the future. One more thing I'm going to say, and then I'm going to leave it ready for questions, is the final thing. I think you guys talked about FHIR in the last session too, and I'm a big fan of APIs in general, FHIR or any APIs for that matter. One of the things you need to think about with APIs, though, is how you manage them. You want to make sure that if you deploy APIs, you put the right kind of management layer in front of it to make sure you're handling the trust, the privacy, the security, and you're handling throttling. You make sure nobody can actually hit your data services and take down your system. So you got to make sure that when you look at APIs, you build it in a way where it's truly an API kind of ecosystem approach, with a API management layer, with a security layer, a privacy layer, a monitoring and throttling layer, a layer of test harnesses so developers can test against some simulated data sets, an environment that really is designed to aggregate APIs and not only serve up APIs in a FHIR context, but even clinical APIs that might be an aggregation of activity streams like what Facebook does, or a panel as an API through an analytics engine like Elasticsearch. You would want to serve up those as APIs too, not just the FHIR specific ones. So you want to make sure that you can serve up APIs. And MiHIN, if you're looking at these kind of technologies, I can see that HIEs are changing significantly, and they're moving more into these data services and platform-like services and aggregation services that are all served up through APIs in the future. Now, I know all of our systems aren't there yet. We're not ready to consume APIs, but every other industry is working this way, and we will catch up, and we will do more and more work through APIs. And I think it will standardize a lot for us and create that real-time capability and the real-time interaction between it. Final thing I want to say, you can tell I'm pretty passionate about these technologies, and I'm passionate because of my son, because I do feel like our system is busted, and I think we can do so much better. And healthcare has an opportunity to take these kind of technologies and actually leapfrog other industries, because we haven't operationalized integration like we should have. All of you know that in this room. We have not operationalized integration like we should have. Every industry has. We haven't created these community ecosystems like other industries. I did this as a career. I created my own company, took it public on B2B integration. It was all about ecosystems. From Procter & Gamble to United Healthcare to big banks, the top 8 banks. They all are based around ecosystems, and they operationalize integration. They're excellent at it. We can do it, but we can leapfrog them. We can do it all in real time. So very excited about that. I think I have 9 minutes left. Is there any questions from any of you? Did I talk too fast? It's an exciting time for healthcare because we do have an opportunity, because we haven't operationalized integration like we should have. We don't have a lot of legacy there. We can actually leapfrog a lot of industries. They're going to have a tough time replacing those older technologies. You know, Procter & Gamble has been using my technology for 10 plus years. They have 70, $80 billion worth of transactions going through it. It's going to be pretty tough to take that out, right? We haven't operationalized it yet. We have an opportunity to do things different, do it right, and do it real time. Any questions? No technical questions?
I'm not personally familiar with the Deer Walk system, but it's been brought to my attention recently as a big data Hadoop kind of thing for storing, retrieving information. Do you see an integration of technologies like that in the future that you imagine?
Like Hadoop?
Yeah.
Yes. In fact, we picked Cassandra. I showed you Cassandra. It could be Hadoop. It could be other technologies. We picked Cassandra because it has some patterns that were important to us. But Hadoop itself is really good for a data lake. I don't know if you've heard those terms, but we use Cassandra for our data lake. We use it more like Apple because we wanted more of a real-time transaction engine, which Cassandra is really well designed for. So the patterns we were trying to support by feeding clinical claims, pharmacy, biometric, genome data through APIs, Cassandra was a better fit for us. We looked at Mongo, Hadoop, we looked at all those technologies. But if you're building just a data lake to help you organize and search and find raw data, it's fantastic for that. But then you're still going to have to push it through some kind of pipeline to put it into a consumable set of data spaces or data models, however you want to describe those. So all those NoSQL systems are pretty exciting in that context because they can offer you the capability to handle the structured and unstructured and help you organize some of that data better than putting it in file systems and things like that.
So I'll just speak loudly. You mentioned that we have to trust APIs. Could you just briefly elaborate on what you mean by trusting APIs?
What I meant from a trust perspective is the actual API management layer that you create has to have built-in trust capabilities to it, and has to have, I didn't really say trust. If I said that, I didn't mean that. Has to have privacy and security into the APIs. So you can't, so for example, and I'm sorry, I don't mean to be getting into products, but our product runs on all those stacks right there. And our privacy layer cuts across to all of that. So anything that an API access touches the privacy layer. So if there's a relationship in there and I'm serving up a panel to a provider, and the panel might be a set of chronic patients or diabetes patients or whatever it might be, it uses the privacy layer to make sure it serves up the right data to that provider. So the way you build your system, because look, the way we built our systems in the past, there are 4 or 5 different systems, which means what? You have to synchronize privacy across 4 or 5 different systems. So we built it in a different way where our privacy is a microservice across that entire stack. So any API served is using privacy services to make sure that I'm giving the right data to the right person. There is no HIPAA violation or PHI issue. So it's really important that when you build your API layer, really focus on security, monitoring, throttling, and privacy. Really work hard on that, because if you don't, you could open yourself up to some risk, serious risk.
Hi, I'm responsible for new technology evaluation at Blue Cross Blue Shield of Michigan, and it strikes me that this precision care may make a lot of our clinical trials that are the bread and butter of our data set that we draw conclusions on obsolete. I was wondering what you think the implications are of the technology that you're describing for changing how we evaluate whether or not a particular innovation works for a patient, since it's unlikely that you can describe the treatment that's sort of a mass description in a clinical trial when you're individualizing care so much. What are the implications there?
Yeah, it's interesting. I think our clinical trials are going to be much less money, right? Because they're going to be much more precise. Because, just like my son's disease, only 4% of the patients actually have that mutation. That mutation protein channel doesn't open properly, and that helps open and close it properly so the ions flow. That means only 4% could have been in that trial, so it's a very small number. So the trials are going to be smaller, faster, and the results should be better. But it's an interesting question because I'm working with several pharmaceutical manufacturers right now that are interested in our technology for a couple reasons. Because for you, they need to prove to you total cost of care is less with this high-cost drug, right? I could actually show you with my son that it's less, and I had to prove that to United because that was our insurer. But yeah, they're going to have to get better at understanding the total cost of care in these specialty and orphan drugs in particular, and they're going to have to be very precise with that. So you're going to have to know, I think, at some point, if this drug costs $100,000, but the total cost of care is $150,000, then it's worthwhile to you. If it's not, you're going to be negotiating with them. I mean, that's going to be kind of the model. We are working with some large payers that license our technology. Horizon, which you would probably know pretty well, they're actually going down the path of precise medicine. I don't know if you've heard some of the cancer things that they're doing, and this platform is the platform they're using to actually do their provider engagement and member engagement and work with one of their precise medicine partners. So it will change pharmaceutical. It will change clinical trials. It should drive down those prices, and it probably is going to get your antennas up from an insurer perspective on how do we make sure this total cost of care equation works and outcomes are really being proven. Which, what does it mean for clinicians? I mean, one of the key things for my son, he has to take that drug twice a day, every 12 hours. So what do you think I'm relentless on him about? You know, it's like, you better take that drug twice a day, you know, and you better take it 12 hours apart. And, you know, he's a 19-year-old kid. He wants to sleep until 2 o'clock sometimes because he's up till 4 o'clock in the morning or whatever. So, and he needs to take it at 11 and 11 every day. So I have to wake him up sometimes to make sure he takes this drug, and he has to take it with fat. So he has to wake up and eat something too at the same time. So medication adherence, to make sure you get that kind of outcome is going to be so critical. You know, so the proactive care models that we're working towards are going to benefit even the precise medicine models, because medication adherence, as most of you know, it's about 60-65% today, medication adherence. If we don't get that in the high 90s, those orphan or specialty drugs won't work. You're going to get minimal outcomes. You're not going to get somebody that looks like that. I don't know if I answered all that, but
Let's give it up for Dave Bennett for sharing that great story.
Thank you. Thank you.